Thank you for your very gracious introduction. It's so nice to be back to this lovely state. I first came to Iowa about 9 years ago as part of the Iowa State Planning Grant effort. I was part of a research team that was put together by the Iowa Department of Public Health under Ann Kinzel to help Iowa study some of the causes of the uninsurance problem in the state and to develop policy solutions. I conducted focus groups in every corner of Iowa with agricultural workers, small businessmen and women, people who worked in slaughterhouses, new residents of the state, and developed a very firsthand feel for the state and some of its challenges. I'd like to emphasize to you, because many of you are academicians, that it was this research and a lot of other health services research studies over the past 2 to 3 decades that provided the intellectual foundation for the national health reform approach that was adopted this past year. There are people who said, well, it came out of nowhere and it was so fast, but I have to stress that what was learned in these kind of studies really provided the foundation for some federal policy. And I'm thinking about understanding the limits of the voluntary market, and I'm thinking about the price sensitivity of populations who are buying health insurance. As director of AARP State Government Relations, I continue to marvel at Iowa, at your level of civic engagement, your commitment to social well-being. Most importantly, I see a state that has forged bipartisan policy-making solutions and indeed bipartisan experimentation, that you have already adopted sweeping healthcare reform in the state, coverage for all kids, medical homes, chronic care management, health information technology, expanding the workforce. You have 8 more advisory committees all supporting this. And the result is that you have a wealth of collective expertise and a commitment to forging real solutions that are grounded in traditional Midwestern values. And in the state, you're also blessed with strong leadership, both in the public and the private sector. And this expertise and mutual trust is going to go a long way as you think about how you want to implement national health reform. I do have to stress that most states don't have this comparative advantage, so I'd like to put your minds at ease as you may be feeling a bit overwhelmed with all that's coming down the pike. So in short, Iowa is poised to take full advantage of this new law. Thankfully, much of the public acrimony has quieted, and the landscape for thoughtfully implementing health reform seems to be improving as people learn about some of the specific immediate benefits of this law. And I'd like to just highlight a couple for you. Tax credits for small businesses. Over 51,000 small businesses, maybe 90% of the state, will be able to take advantage of it. Many of you have adult children in college who are or leaving the nest who have not been able to get health insurance, but now about 8,000 young adults will be able to get coverage. There's a transitional high-risk pool where there's $34 million coming into the state for people who have pre-existing medical conditions and who couldn't buy insurance at any price. That's happening now. There's no coverage denials for children. They're going to require plans to provide preventive care with no cost sharing. There's no more annual or lifetime caps. That will assure that over 1.7 million folks in Iowa will not have to worry about reaching the end of their coverage protections. There will be no more rescissions. Insurers can't drop a person's coverage when they have major health problems. And there's a rebate for seniors in the so-called donut hole. And last year, roughly 43,000 Iowan seniors fell into this donut hole. So this is just a snapshot of what is available right now. There are some challenges to health reform on the horizon. I know that you've been reading in the paper, or you've heard about, in Congress, there's fights about getting enough money to implement this law. There are state budget ballot initiatives in Arizona, Colorado, Florida, Oklahoma, and Missouri. These ballots have confusing language. It's really uncertain what that outcome will be. There are attorneys general in 20 states, plus Virginia, who are challenging the constitutionality of the law. And in over 40 states last year, bills or referendum were introduced to somehow put gunk in the wheels of moving health reform forward. But in the midst of these uncertainties, I think it's important to stay focused and, like good Iowa football, keep the ball moving across the finish line. My objective today is to offer some ideas about health reform, both as an economic engine and the possibilities for health system transformation that it offers. And this can be fostered through collective, coordinated, and sustained policy efforts. Y'all just can't go off in your little holes. I mean, you really need to be integrating all this. And in Iowa, it seems that the key challenge is to integrate what you already have and are developing with the new federal law. So let me highlight 4 different areas that may be interesting to you. First, to continue to simplify and integrate eligibility systems for Medicaid and Hawkeye and other public programs. With Medicaid expansions for adults up to 133% of poverty and no companion asset tests, nearly half of Iowa's uninsureds will now have Medicaid coverage as a result of this new federal law, and an estimated $2.9 billion in new federal Medicaid funding will come into Iowa over the next 10 years, which will purchase vitally needed medical services across the state. Dramatic simplification of often county-based eligibility is the only way to achieve the promise of health reform without breaking the bank. It will be impossible to enroll hundreds of thousands of new people without changing a cumbersome and antiquated and often intrusive eligibility platform, given its former link to aid to families with dependent children. The technology for Medicaid eligibility and system processing is outdated and expensive to modify. The federal law simplifies Medicaid eligibility by moving to a standard based on modified adjusted gross income, as defined under federal tax code. This simplification is intended to mesh with the income tests for exchange-based subsidies. With yet to be published federal guidance, states must completely redesign their eligibility processes to assure seamless transitions for individuals between Medicaid and the exchange as their income or family circumstances changed. Iowa has learned a lot about effective outreach, but part of what you've learned is that outreach is only effective in the context of improved eligibility systems. So now it is critically important to assess what you have and look at the technical capabilities, IT infrastructure, streamline, harmonize, do what you can, and make plans for addressing any risks right now so that you can take advantage of these federal changes. The next thing I'd like to highlight is designing a pro-consumer exchange. You've read about exchanges, and in some, it's just simply a new marketplace where individuals and small businesses will be able to purchase health coverage and through which subsidies will be administered. So important is this that it needs a coordinating and sustained body to keep linking it through with other programs within the state. It just can't operate in isolation. There are 2 different models for exchanges and anything in between. You've read about Massachusetts, and there is a lot that's been learned about how it's set up, the silver, the gold, the bronze plans, and how there's differentiation of different benefits within that. Also, they've learned that even as simple as the exchange seemed to be, it was still confusing for consumers. That's on the one side. The other side is in Utah, which is basically, an IT platform for advertising your insurance. So a state can design its infrastructure any way it really desires, and that's an important policy objective here. and urgent. By the time the exchange is fully implemented, nearly 2 million of folks in Iowa will be eligible for the federal subsidy or Medicaid. And I'm thinking that that's 2/3 of your state. Think about this, 2/3 of Iowa residents have incomes below 400% of poverty, which is basically $88,000 for a family of 4. And so they'd be eligible for the subsidies through the exchange or Medicaid. And the exchange could become the vehicle by which the vision of Healthy Iowans 2010 is realized. You know, imagination is what's needed as we're going into this new territory, because there are so many ways to think about an exchange, how it could be transparent, how you can get public input, how there would be oversight, how it would be useful in terms of robust outreach to consumers and businesses, and manageable number of meaningful choices, and a culture of problem solving, and a can-do kind of attitude. The exchange can also cut waste and be frugal and make sure that consumers are getting the best value for their money. It can set standards for high-value coverage and minimum benefit design. It can accept only products that meet certain public health or delivery system specifications, e.g., that it has to provide medical home, quality measures, consumer satisfaction. It can also adopt a negotiated pricing structure so that products aren't listed on the exchange without powerful voices who represent the exchange pushing back to get the best benefit at the lowest cost and the highest quality. And indeed, the exchange could pay bonuses for these quality improvements. The exchange could design basic, easily understandable, and comparable information for consumers and businesses. Because as you all know, when you try to find a product, it's just impossible to compare one to another. But our fear is that the platform, you're going to need a platform that's going to link this exchange with Medicaid, with the plans, and with the IRS. And so the technical capabilities are it's going to be a very challenging thing to do. The last thing you want to do is ship it off into some arcane agency and not pay attention to it anymore. It really will become the guts, the embodiment of the promises of health reform. I'd like to highlight another part of health reform that not too many people know about, and it's a huge surprise that there are many different elements of this law that provide strong incentives to build home and community-based services and improve the quality of care in nursing homes. You know, we focused on insurance and we focused on Medicaid, but long-term care is a very, very important part of this law. And given all the work Iowa has done to improve care coordination, you can take advantage of many of these provisions. There's a community first choice part, which provides enhanced FMAP for a new state plan option for Medicaid home and community-based attendance services. There's a balancing incentive payment system that expands FMAP for enhanced Medicaid community-based spending. There's the Money Follows the Person extension through 2016, and there's protections against spousal impoverishment for a family member who is receiving Medicaid home and community-based services. There are huge delivery system reforms that are possible under this law too. An expanded workforce, training, residency, physician payment improvements under Medicare and Medicaid. There's grants for community health workers, community transformation, lower pre-Medicare costs. There's grants for improving trauma care, community health centers, and reducing health disparities. So I encourage you all now, even if you're not working in the public domain, to keep your eyes open for funding opportunities that will help you build on the medical home and community health work that you've already accomplished, that is already underway. And use your positions of leadership to foster delivery system improvements that have been highlighted during this health debate. And I'm thinking, for example, about transitional care planning, where we learn that 20% of Medicare beneficiaries, once they're discharged from a hospital, end up back in the hospital after 30 days and they've never seen a physician. Now, what is that about? And that can be changed. You don't need a federal law. You don't need a state law. You just need to change the way you do business. And I think all of us have become educated through this process, and it's like, wow, you know, we can do something different. So just as we're fired up with anticipation and about fulfilling the promise of health reform, there are constraining forces, money problems at the federal, state level, public anxiety about all this, aging IT structures, health and state workforces that are retiring. Those are constraints that we're facing and we'll have to deal with. But for all of us who have dedicated our professional lives to medical care, health research, public policy, or improving healthcare delivery, this is a momentous moment in our lives. And I'm sure that you feel that it's an honor and a joy to have the chance of making the promise of health reform a reality for the residents of Iowa. To make coverage more affordable and the health system more humane in a way that delivers better value for what's spent, this will take years of sustained effort. As the Vice President noted to the President after the bill signing, this is a big deal. At the same time, it's also true that every new and existing problem in the health system will be blamed on this new health law. As one congressional staff member noted, if it rains on a church picnic or at the state fair, someone will blame it on health reform. So as academicians and policy leaders, you would not be here today at today's symposium if you didn't share a deep interest in this new health law and a commitment to sharing your knowledge widely with others. Your leadership, your teaching, and spirit of inquiry will be essential as the state's healthcare system and public sector sort through the elements of this new law and put the heartland stamp of quality onto what is produced in Iowa as a result. Implementation of healthcare reform is coming in the best and worst of times. Seasoned professional staff may be downsized with budget cuts. AARP and other organizations, other advocacy organizations, are eager to help fill in these information gaps because of our dedication to good citizenship and the goal of providing affordable, high-quality health care to all individuals across the United States and all the consumers that AARP represents. We will continue to advocate for significant involvement of consumers in all aspects of health reform implementation. We look forward to working with you in the future. Thank you so much.